Now let's talk about the glomerular diseases. In the glomerular diseases, we have the nephritic syndrome and the nephrotic syndrome. Okay. And just to mention the difference of nephritic and nephrotic, I don't know if they, let's see if they, so let's just, and we have the nephritic nephrotic syndrome mixed features basically. So for nephritic syndrome, we have we see, I'm just going to mention three things here: low GFR, hypertension in nephritic syndrome, and hematuria. And there are lots of things, but just remember these things. Nephrotic syndrome, we have serum albumin, low serum albumin because of lots of proteinuria. We have edema because of proteinuria. And we have proteinuria greater than, although we also have proteinuria here, but that is going to be less than 3.5 milligram per deciliter. And here you have greater than 3.5 proteinuria. Okay. So let's now read what the book has to say. Okay, so in nephritic syndrome, and this is the nephrotic syndrome. Nephritic, we have hematuria. We can see it from the RBC coming out. What are these cells? We have the proteinuria, but look at the proteins, they're very minimal. So it is the less than 3.5. We have the proteinuria, but it is only less than 3.5. And decrease in GFR and hypertension or other features for nephritic syndrome. As far as nephrotic goes, we have hematuria, but that's so less. So now their proteinuria is there. That's why you have the proteinuria as the hallmark here. Greater than 3.5. We have low, that proteinuria, protein goes out, causes low albumin, causes edema. Okay. So also look at the glomerular filtration barriers. We have the podocytes, we have the basement membrane, and on top of that we have the fenestrated endothelial cells, glomerular capillaries, or the extra things, and urinary Bowman space. So if you have both of them all together, you have hematuria and proteinuria, right? So let's read nephritic from etiology-wise. Nephritic, there is a glomerular inflammation leading to glomerular basement membrane damage, leads to loss of RBCs into urine, leads to dysmorphic RBCs, hematuria. Classic presentation is hematuria, RBC cast. Hematuria means a lot of blood, so RBC cast definitely, decreased GFR definitely, and hypertension and increase in renin leading to hypertension. Proteinuria often in the subnephrotic range, less than 3.5, I have mentioned that, but in severe cases maybe in nephrotic range. Well, just remember less than 3.5. Example is either infection-associated glomerulonephritis, Goodpasture syndrome, IgA nephropathy, Berger disease, Alport syndrome, membrane proliferative glomerulonephritis. For the nephrotic syndrome, we are looking at podocyte damage. When you damage the podocyte, it causes impaired charge barrier, and we are trying to have the negative charge to have that barrier, and that was coming from the heparin sulfate. And we lose that, it causes the negative charge albumin to go out and causes proteinuria. Massive proteinuria greater than 3.5 grams per day with edema because of that protein loss. Because of edema, hypoalbuminemia, hypoalbumin because we are losing protein, in the urine causes hypoalbuminemia. Increase in hepatic lipogenesis, which causes increase in cholesterol. So we were losing lots of proteins, thinning the blood. So the liver tries to buff it up, and by causing increase in lipogenesis, increases in the cholesterol in the blood causes hypercholesterolemia. You will see frothy urine with fatty cast associated with a hypercoagulable state due to antithrombin. Excuse me. Proteinuria, also leading to loss of antithrombin 3 in the urine, leads to hypercoagulable state and increased risk of infection because of loss of IgGs in the urine, and soft tissue compromised by edema because of albuminuria. What are the diseases? Could be primary, like direct podocyte damage, or secondary podocyte damage from systemic process. Focal segmental glomerulosclerosis, primary, secondary, minimal chain disease, primary, secondary, membranous nephropathy, primary, secondary, amyloidosis, secondary, diabetic glomerular nephropathy, secondary. Now we have a couple of diseases in which we have nephritic and nephrotic all together, both of them. Which are they? Can occur with any form of nephritic syndrome, but is most common with, very important, diffuse proliferative glomerulonephritis. Membranoproliferative glomerulonephritis. Okay, so all the proliferative ones, we have both all together, in which we are losing the barrier as well as we're damaging the glomerular basement membrane. So severe GBM damage, loss of RBCs in the urine, plus impaired charge barrier, hematuria, proteinuria, nephritic range, proteinuria greater than 3.5, and concomitant features of nephritic syndrome. So that's pretty much all we have for glomerular diseases, being just an overview of them.